Next, I have Skye Tikkanen. She is going to come up, and she has a bunch of letters behind her name. And she has a great story. She's going to come up here and kind of talk about the stigma, and also from there move into some of the ways that we can talk to people suffering from addiction and intervention type language, so that we aren't, so we can try to avoid some of the missteps that a lot of people make. So thank you, Skye, for coming today.
Good morning, everybody. I'm a little bit shorter than the rest of the presenters. So before Mary walks out, I just want to say something quickly. I come to this advocacy work from a place of my own recovery. I'm one of the success stories. Mary comes to advocacy work through a very different path. And I find it incredibly brave and moving that through her own tragedy, she has given back to the community and to so many others in such profound ways. And now she's gonna try to walk away and not accept my compliment. All right, so we're going to talk a little bit about substance use disorders and the stigma around those today. I feel like I'm a little too close to the microphone. You guys are getting some S's.
Will we get that in your presentation?
You are welcome to it. Yep. If we can go ahead and go to the next slide. All right. So, yes.
You need to be closer.
I do need to be closer.
We won't record it otherwise.
Okay, got it. Better? All right. Okay, great. So this map is a map of Wisconsin. You can see that each of the counties is reflected here. The darker the color of the county, the more opioid-related deaths have taken place in that county. This is good data. It shows us how horrible this epidemic is, but it is not the way that I want you to think about the epidemic. This is a quilt that was made by a mother who lost her child to an opioid overdose. Unfortunately, there are 2 more of these quilts now. When we are thinking about this epidemic, I want you to not envision the epidemic as different colors on a map or death tolls. I want you to think about each and every person that was lost. Each of these people have a family, they have friends, they were probably at some point part of the workforce. These people had lives that were meaningful, and their disease of addiction cost them their lives. The more that we can get in touch with the human part of this epidemic, the better our response to it will be. This isn't just statistics, it's people, and it's people that are impacted in our community. I want to go over kind of what the risk factors for addiction are. We have some really good science now, and we can predict with pretty good accuracy a person's risk for addiction. The first risk factor is just your DNA, right? So at the time that you were born, did you have a family history of addiction? The more family history, the stronger that risk becomes. And that's 40 to 60% of addiction risk right there, is just the genetics that you were born with. The next risk factor is adverse childhood events. Adverse childhood events, and you'll learn more about these in the movie that comes over lunch. Each one you get a chance to kind of go through and see how it's impacted some of the people in the video. But what they really are bad things that happen to a child, right? And some of those bad things, we can kind of predict, right? Like, oh yes, if there was domestic violence in the home, a child would be more at risk for addiction. If a parent was incarcerated, a child would be more at risk for addiction. But some of them are things like not feeling understood by your family, right? And that's not something that springs to mind when we think about what puts somebody at risk for addiction. Another one is whether or not the parents are still married, or if there's been a divorce when the child was still a minor. So 4 or more of these events, and the more of these adverse childhood events that you've had, the more likely you are to have a substance use disorder. Your risk goes up by 50 to 66% at 4 adverse childhood events, right? So far we have genetics, we have the bad things that happen to kids when they're kids. And now let's talk a little bit about co-occurring disorders. So co-occurring mental health disorders are another big risk factor for developing a substance use disorder. What the research says is that about 85% of people that present to a substance use disorder treatment facility have a co-occurring mental health disorder. The state of treatment and its ability to be accessed is not great in our country. Actually, I would say it is pretty poor. About 1 in 10 people in this country receive treatment for their substance use disorder. Only 7.4% receive treatment for their mental health and their substance use disorder. If we're not treating the whole person, if we're not treating everything that's going on with people, we just set them up to relapse. When I started in the field, I started as a substance use disorder therapist, and it didn't take me long to realize that if I did not get my education in mental health treatment and trauma treatment, that I was doing my clients a disservice. I needed to be able to support these people who had no reason to trust me and no reason to trust anybody with all of those complex issues that were going on in their life, not just their substance use. I mentioned trauma. I did not expect to become an expert in trauma when I went into this field, but that's where life takes you. So I actually think that this number is underreported because trauma itself is so underreported. It's still a huge number, right? So what the research says right now is that 77% of people that enter into a substance use disorder treatment program report past trauma. I can tell you from my anecdotal experience that I've never had a client who hasn't had some type of trauma. I do really like to work with the most challenging clients, so that it might not be a great representation of what happens with everybody. My clients all have severe substance use disorder, co-occurring mental health, and complex trauma. They are the ones that haven't done well in other programs, and I love them like you don't even know. They are some of the best people that I've ever met. To see somebody who truly has no reason to have hope or to have trust or connection to another person that overcomes that to try and keep trying over and over again to be a better person, to reclaim their life, and to hold on to their humanity. I think it's the most beautiful thing about people, and I get to see it a lot in my work, which makes me really, really happy. So I do not read things off of slides because I find it annoying when people do that to me. But here is a list of all the adverse childhood events. You guys have access to my slides, so you can look through them on your own time. So let's talk a little bit about why it is so important to treat mental health and substance use disorder at the same time. People that use substances are looking for something that they're not finding in their life, right? There might be some experimentation, right? But people who continue to use, there's something that substance is doing for them that they're not getting in their regular life. So what that means is that the substance becomes a self-destructive coping skill. right? So whatever their problem is, whatever is making them feel uncomfortable or causing them emotional pain in their life, whatever that is, the substance is covering that up for them. So it's almost treating whatever is underneath. It is not a positive treatment. People should not use that treatment, but there's a reason why people use substances. I've never met anybody who didn't have a reason. When you take that self-destructive coping skill away, the mental health symptoms and the trauma will come back, and they will come back stronger. So unless you're treating both at the same time, you're not going to get positive results, and you really do set somebody up for a relapse. All right, so on one side of this chart, you'll see the PTSD symptoms from the Diagnostic and Statistical Manual 5. That is the Bible of diagnoses. On the other side, you'll see the effects of opioids. If you look through this, you can see that a person with post-traumatic stress disorder receives relief for every single one of their symptoms by using opioids. They are not stupid. We are not stupid. We don't come to using because, we got this crazy idea that maybe shooting heroin would really help our lives, right? We come to it because it's helping us manage life. When your life is so painful, when you're waking up with night terrors, when you're having flashbacks every day, and you find something like an opioid that calms everything down and makes you feel okay, right? Of course you're going to continue to use it. It's not a good idea. It doesn't work over the long term, but it makes sense in that moment when a person is desperate. Let's talk about why it doesn't make sense over the long term. So I show this chart to my clients all the time. And it's not like exactly reliable, right? So it is very close, but I call it the easiest chart in the world. And so it gives you the general idea of how coping skills work over time. So a person who's struggling in life, who starts at a lower baseline than others because of those struggles, the first time that they use a self-destructive coping skill, like using a substance, gambling, chaotic relationships, cutting, whatever it is, right? That self-destructive coping skill is going to work amazing for them, right? Whatever they're struggling with, they're not going to feel it. They get their dopamine going, they get their endorphins going, everything feels great. When a client uses meditation or yoga, progressive muscle relaxation, journaling, all those healthy coping skills, the first time they use them, they look at me and say, "Why did you make me do that? That didn't help at all." And they're right? Like, they barely work at first. But the thing is that the longer you use healthy coping skills, the more effective they become. Richie Davidson over at UW has been studying the Dalai Lama's brain for years, right? And what he's found is that people who engage in those healthy coping skills, like meditation, like the Dalai Lama does, way more than anybody else, right? Their brain actually changes from reactive to responsive after 21 days of consistent meditation. So the longer you use those healthy coping skills, the better they work. But somebody needs a cheerleader, right? Somebody needs someone in their life that's saying, "Yep, I know that when you started using this, it didn't work for you, and you didn't know why you were doing it, but keep doing it, because I promise it actually will work if you keep going." That's hard to do when you're struggling. With self-destructive coping skills, all of them lose their efficacy over time, right? So a person's tolerance goes up. They need more of the substance in order to be able to achieve the same result. And over time, it stops working to treat whatever they were looking for help with in the first place. When that happens, they actually go lower than their baseline. So their mental health symptoms, their trauma symptoms, whatever it is that they're struggling with actually get worse. I told you how much I love my very complicated clients. A lot of them come to me not because of criminal justice intervention, not because parents were worried, but because the drug stopped working, right? When they come to me, they say, I'm still using every day, but I'm having flashbacks at night. I can't sleep. The drugs don't work anymore. I don't know what to do. And that's when we really start to dig into those healthy coping skills. Try to treat what's underneath that desire to use in the first place. Okay, all of you are wonderful, lovely people. When you see this precious little girl who told her mom that she was being sexually abused, if she came into your life in any way, how many of you would skip lunch to help her? Right? Think about what you would do in order to help this little girl, right? Like, how far would you go? What would you be willing to do to provide this little girl the support and love and compassion that she needs? If that little girl, if her abuser said that he would kill her parents if she told, if that little girl decided to tell, but her parents didn't believe her, that little girl becomes this woman. When you meet this woman, she will not like you. She will not trust you. She will probably swear at you. She doesn't have any reason to trust other people. Her life has taught her that people hurt you. So she will be very defensive. We know that early childhood sexual trauma vastly increases the risk for substance use disorders. We know that early childhood sexual trauma vastly increases the risk for prostitution later in life. This woman has suffered so incredibly much. But if she came into your life, what would you be willing to do for her? Right? And it's hard. It's hard to change the way that we're wired and to really see that child in pain inside of that adult that is really challenging to deal with. It can be even harder with different communities. So in Wisconsin, 30% of African American men in Milwaukee are incarcerated right now, most of them for drug crimes. Those men were also little boys once that went through horrible things and struggled throughout their lives, right? We have to be able to find that child inside of that person in order to access our own compassion. The LGBTQ community has been hit the hardest in the opioid epidemic. 3 times the number of people in the LGBTQ community are incarcerated for their drug use as any other community. We're losing more people in the LGBTQ community to opioid overdose as a percentage of population than any other group, right? These people aren't gonna look like that little girl, but that child is somewhere inside of them. All right, so I want to talk a little bit about how addiction impacts the brain. And I have noticed over the years that when I start talking about neurotransmitters, my audience's eyes glaze over. So I am going to do my best to make this interesting. Who likes cupcakes? All right, okay. So what this slide shows is that when you eat not so healthy food like a cupcake, what happens is that some of your dopamine is released, right? Which is why we're all like, yay, cupcakes. Dopamine makes you feel good, right? When you take a substance, all substances mimic neurotransmitters. That's how they impact the brain. So when you take a substance, instead of a little bit of that dopamine being released, your brain is flooded with dopamine. So you feel really, really, really good, right? What happens over time is because that substance mimics the neurotransmitter, it doesn't actually fit in the receptor site for your natural neurotransmitters the right way. So over time, it changes the receptor site in the brain. When that happens, the brain needs to heal before you can enjoy natural pleasure. So when a person has been addicted to opioids and that receptor site has changed its shape, the brain does heal, right? Brains are amazing things, and brains do heal. But it takes 2 years for the brain to fully heal. So that's 2 years before a person walks outside on a day like today with the sun shining and the birds chirping and experiences that same level of happiness that all of you in this audience will, right? That's a lot to ask of a person. It does get easier, it does get better over those 2 years, but it is still, it's 2 years before they feel the same type of happiness that you or I would. This is a PET scan of the brain. I do not like the word drug abuser. I'm just going to put that out there before I talk about it. These are old slides from SAMHSA, the Substance Abuse and Mental Health Administration. And I don't like that term, so I am just going to say something different. The first picture is a healthy brain. The second picture is a brain in active addiction, right? And you can see how the way that the brain works is changed. Positive thing, when a person gets into recovery, this person struggled with meth as their substance of choice, and after 14 months, their brain has healed, right? So recovery is possible, healing is possible, and it takes time, and a person really needs to be supported during that time. One of the things that drives me crazy is that as a treatment professional, people will sometimes say, well, your outcomes are awful. I don't even think treatment works. And based on some old data, I could understand why people think that. So there's a number that gets tossed around, 13%. And that was true when we were measuring addiction in a very strange way. So if you go to the doctor with a broken ankle, they put you in the cast comes off over time, right? And then you're not likely to break your ankle again. If you are diagnosed with diabetes, you are on a treatment regimen for the rest of your life, right? We used to study addiction like a broken ankle as opposed to like diabetes. We thought it was a one-time acute event, and then, send somebody to rehab for 30 days. Then that will fix them. They will go on with their life. They will never use substances again, and everything will be perfect. It doesn't work like that. Addiction is a chronic brain disease. When we started to look at our outcomes compared to other chronic diseases, look at us, we do really good, right? So we actually have better outcomes than type 1 diabetes. Hypertension and asthma, they're still beating us, but we're doing more research. We're trying new therapies. We're gonna get number 1 at some point. The better that you study something, the better you understand it. You can see that treatment does work and it has a positive impact in people's lives. All right, medication-assisted treatment is a valuable evidence-based tool in the fight against addiction. So there are a number of different medications that people that struggle with opioid use disorder can use. The first one we'll talk about is naloxone, which is just an opioid overdose reversal agent. So when a person has had an overdose, you can administer naloxone, and it's like a miracle. They come back to life, right? Naloxone in our state is legal for anyone to have or use in a good faith effort to save another person's life. Safe Communities, where I work, we have 4 community naloxone training events a year. If you'd like to get trained in how to administer naloxone and perhaps save somebody's life, you are welcome to join us. You can also go into any pharmacy and request it, and it's usually about $40. So the more people who have naloxone, the more lives we save. The next is Vivitrol. Vivitrol is a shot. It's the same substance as naltrexone, which is taken as a pill form, and it blocks the opioid receptors. So if you're on Vivitrol or naltrexone and you use an opioid, you won't get any effect from them. Subutex and Suboxone are partial agonists, which means that they're partial blockers. And the way that they work is that there's still a little bit of opioid in there. And for my patients, because they are so complex, this is usually the medication route that I start with them. Having, an opioid in their brain for 10 or 15 years and then taking it all the way away has not had great outcomes for my very complicated clients. So starting with Suboxone or Subutex and then weaning them down over time has much better outcomes. But that is just based on my caseload, which are those really, really, really complicated people. The next medication-assisted treatment is methadone. Methadone's been around forever. It has been studied up and down. It definitely works. There isn't a ceiling effect, so people can continue to have that sense of euphoria on methadone. And this is like my real objection to methadone, is that there's a lot of sugar in it, and I don't know why they formulate it with so much sugar, but a lot of people develop type 2 diabetes after being on methadone for a long time. So I prefer my clients to not use methadone, but if they do, then I'm absolutely fine with that, right? So it's got to be what works for each individual person. But I don't want them to get type 2 diabetes, and I wish that they would formulate it without so much sugar in it. It's a good medication. Why has it got to have so much sugar? All right. So I'd like to give you a way to think about addiction based on the science, but in a format that might be a little bit easier to understand. So does anybody recognize this? Yes, right? You guys all took Psych 101. Good job. All right, so Abraham Maslow came up with the hierarchy of needs in like 1840, right? This has been around forever. It has been studied over and over and over again. What the research shows is that those physiological needs, like breathing, food, water, shelter, those needs have to be met before you can get to the next level of needs, safety. After your safety needs are met, after you don't feel scared for your life or the lives of people that you care about, then the next 3, love and attachment, self-esteem, and self-actualization, those actually can go in whichever order based on the person's personality. right? So what's important to them. But those first two, they stayed the same for hundreds of years now, so we can probably trust them. What we know is that when mice are studied and given the choice between food and an addictive substance, many of the mice will starve themselves in order to be able to continue to use the addictive substance. So what the addicted brain's hierarchy of needs looks like is really that substance or compulsion before physiological needs. Clearly there can't be human trials of this because that would be incredibly unethical, but that there is research from communities that also supports this. People that are homeless and lose their shelter due to their continued need to use a substance are a good example. So when a person is in active addiction, their brain is telling them that that substance or that compulsion is necessary for their survival. Even more necessary for their survival than the things that are actually necessary for their survival. The reason that I think it's so important to understand this is because people in active addiction do bad things, right? They steal from their families. They commit petty crimes, right? There's lots of things that we could, wag our fingers at that people in active addiction do. And when we're doing that, we can come to the conclusion that they do bad things because they're bad people. They are not bad people. They are desperate people. If a person's physiological needs were threatened, what would they do in order to survive? Would they steal? Would they lie? Would they cheat? When your brain is telling you that that substance, that compulsion, is more important than what your body actually needs to survive, what would you do in order to be able to survive? All right, nobody gets out of a presentation with me without knowing what they can do to help. I don't think it's fair that I do all the work. You guys got to do some work too. All right, effective interventions for people with substance use disorders are a balancing act between compassion and accountability. Ways that you can be compassionate. This is a really simple but very profound concept. Understanding the difference between guilt and shame is so important. So guilt is a really useful emotion, right? I have a client that comes in and says, I relapsed, I didn't even enjoy it because the whole time I was thinking I have to come and tell Skye that I relapsed and I'm gonna have to tell the group and I feel awful about it, right? I'm doing my happy dance because they are less likely to use again because they feel guilty about their relapse. It is a useful emotion. It's an understanding that they made a mistake. Shame takes it too far. Shame is not, I made a mistake. Shame is, I am a mistake. Shame is, I am a drug addict, a junkie, a criminal, and that is all I will ever be in life. So why should I even try? Shame shuts out hope. Without hope, there is no motivation for people to change. One of the easiest ways that you can start to push people away from shame into guilt is just by the language that you use. I identify myself as a person in long-term recovery. I do not like it when people call me an addict. You don't call people that have cancer a cancer. Don't call me an addict. all people who are in recovery get to decide how to label ourselves, right? So some people are very comfortable with that, and they can call themselves anything that you want, anything that they want. If you are not a part of our recovery community, you cannot, and you need to use the most respectful language possible. All right, when you know somebody who is struggling with the disease of addiction, let them know that you are concerned about them, right? No finger wagging. No, do you know what you're doing to your family? Don't push them into shame, right? Let them know, I am scared for you. I care about you, and I see what's happening, and I'm worried, right? That has a much more powerful message than telling somebody, no, 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 just stop using, just pretend you don't have a brain disease and say no, just change everything about your life tomorrow, it'll be fine. All right, let them know that there are resources to help. At Safe Communities, in collaboration with the Parent Addiction Network, we spent an awful lot of time creating a treatment resource map. Please, 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 please use it. We put so much stinking time into this thing. If people aren't using it, I will cry. There is like workflows for every single funding source. So if you know somebody who needs help, you can look at their funding source. It determines whether or not the services that they can access are for men or women, for minors or adults, and what level of care they can access at all of the different treatment providers. So please use it. It is very helpful, and we really put a lot of time into it. And then going back to that Maslow's hierarchy of needs, right? Treat them like they're a sick person. Treat them like they're a desperate person. Don't treat them like they're a bad person. They are not bad people. Let's talk a little bit about protective factors. We talked before about the adverse childhood events and those risk factors. I've listed a couple of protective factors that every single person in this room could do for somebody. So, when a kid has a non-parental trusted adult to talk to, they're less likely to develop a substance use disorder. Can you be that person in somebody's life? Is there a kid in your life that is not your kid that you can develop a relationship with? That when they are a bratty teenager and they don't want to talk to their own parents, they can still talk to you. Having enough money to eat and get medical treatment, right? Living without the basic necessities does increase people's risk for substance use disorder. You know, what do you donate to a food drive? Are you active in charity work in your community? If you are, then you're helping to prevent people's addiction. Kids that are involved in a church or community group are less likely to struggle with the disease of addiction. I bet every single one of you has some type of skill, some talented people out there in the audience, right? I bet you could lead a church or community group for kids or teenagers, and that works to prevent addiction. Kids that have dreams or goals are less likely to struggle with a substance use disorder, right? In your interaction with kids and teenagers, can you ask them, like, what do you dream of in your life, right? Like, what are your goals for the future? Really simple things like this, you become a very positive part of the community that prevents addiction throughout our community. And then positive family relationships. What are you doing to support families that are struggling, right? Because the closer that that kid is with their parents, the more protected that they are. So if you see a family struggling, what can you do to help reestablish those bonds between children and parents? All right, and now I'm open for questions if anybody has them. Yes? Oh, that is a good question. Um, Yep, absolutely. So the question was, how long does it take for the brain to deteriorate? It takes 2 years to fix, but how long does it take to deteriorate? And it really is substance dependent. I mean, the research isn't there to give us a clear guideline. So definitely after 5 years, you'll see PET scans like the ones that I showed. And then I don't think I can give you a clearer timeline than that. It takes a while, but the research is not exactly clear, and it does depend on the person's like genetic makeup and then also the substance used. Yeah. Other questions? The question was, have I heard anything about the buprenorphine shot? I have. I'm very excited about it. I think that this, with the buprenorphine shot and with the Vivitrol, we really have an opportunity to get our doctor community to start providing medication-assisted treatment to people so we can increase access to treatment. And it's not covered by insurances in this area as of yet. I know. So hopefully they'll get around to adding it to the formulary soon, and then we can really make a push to make sure doctors are involved. So Badger Care has been excellent about medication-assisted treatment. They're the ones that have led the charge. I haven't seen anything that they've added it yet, but it did only get FDA approved like a month and a half ago. So it's a process. Healthcare organizations don't move incredibly quickly. Yeah. Mary knows what I'm talking about. Yes. So I don't know if we have printing capabilities here, but we can get email addresses and then send the slides to you that way. Yeah. Yes. So low dose naltrexone, there is some research that you can start a person on low dose naltrexone while they're still using an opioid without starting the chemically induced withdrawal process. But it hasn't been tried very often. And is that the question that you're asking? Yeah, I mean, it's pretty new in the medical literature, and I'll just be totally honest with you. I don't like my clients to be guinea pigs. I like other people to do that, and then for it to be studied, and then to know that it works, and then I'll refer my clients to it. That's kind of the way that I work. Nice.
There's a lot of testimonials, and I kept thinking of, people who have substance use.
Yeah. Okay, excellent. I will look into it more. Yeah. Thanks. Yes.
When you talk about the susceptible to substance abuse related to trauma, I just wonder whether they ever have researched why some people have trauma but never anything happened to them. Maybe they had something happen but not substance abuse, but
Yeah.
why are they more susceptible?
So there's actually a couple of reasons for that. I think a year and a half ago, maybe 2 years ago now, there was a gene identified that actually puts people at additional risk for PTSD, right? So part of your genetic makeup is if a trauma happens in your life, are you more likely to find resilience through that trauma, or are you more likely to respond with trauma responses, right? The other part of it is when it happens. So developmental trauma is much more harmful for people than trauma that would happen as an adult. So, my kids when they were little didn't think that I existed when they couldn't see me, right? They're so self-centered, developmentally appropriately so, right? But they're so self-centered that they don't see outside of their own lens. What we know happens psychologically is that because children see the world in that way, if they experience a childhood trauma, they believe it's their own fault, that they are dirty or broken, that there's something wrong with them that caused another person to treat them that way. So, the earlier the trauma takes place, the more harmful it is. And then the third thing is that, we always have, risk factors, but we also have resiliency or protective factors. And so the more resiliency or protective factors that a person has, even when they have suffered a trauma, those can outweigh so that they come through it in a stronger place. Excellent question. Yes? You can, so there's not the same type of ceiling effect. So if you're on a stable dose of methadone, then you won't. But if you continue to up your dose, then you can still access those feelings of euphoria. Does that make sense?
So is the same methadone used for heroin addiction, or is that the same as for pain, severe pain?
It is, yep. It is. A lot of opioids have medical uses. Yep. And so, and there's, some interesting studies coming out about the use of Suboxone for chronic pain because it does have so much less risk than a chronic opioid therapy. Yes.
The dual diagnostic model.
Mm-hmm.
Can you kind of quickly walk us through what that looks like?
Yeah.
And secondly, in your opinion, what do you think is missing in that dual diagnostic model use of opioids?
Great questions. So there's a couple different ways to set up a dual diagnosis or co-occurring model. SAMHSA has some really great guidelines. One of them is for resource scarce areas where there is a duly licensed therapist that instructs the staff on how to manage these complex cases, right? So it's still separated services. It's a substance use disorder counselor and a mental health counselor overseen by a duly licensed therapist. And in resource scarce communities, that's the best model that there is. For resource-rich communities, you really want one person to be managing the substance use disorder and the mental health condition at the same time, with the involvement of a psychiatrist and or addictionologist. That's the model that I prefer, and in Dane County, we're lucky enough to be resource-rich. So most of our treatment programs have been able to utilize that model. Treatment alone, right? I've never had anybody, find and maintain their recovery because they spend an hour a week with me, right? That's not where recovery happens. It's a good starting place. Don't tell other people this, but I give my cell phone number to my clients. At the beginning of their treatment, I want those phone calls from them. I want those texts from them. And then I want to help them develop a recovery community. So the more that I can get them connected with other people in the recovery community, that's going to strengthen their own recovery. It's going to strengthen the recovery of the person who is, asking them to come and go to sober events or meetings or whatever it is. It's just a really good model. And then, having the family piece in there. The way that I refer to it is that it's get client X sober team, right? And I want as many people on the team as can possibly be. So family, friends, significant others. I want us working together to support this person, and that does not happen in a 53-minute hour in my office. It can start there, but it has to expand out into a person's life. That's just fine.
When you were talking about you help a client with two things, one is compassion, the other is accountability.
Yep.
I remember I watched a capsule about everything you know about addiction is wrong.
Yeah.
You have
Yep.
watched that, right?
Yep.
But they didn't talk about accountability and how do you make it accountable?
So accountability is really important because when a person's brain is in active addiction, lying is a symptom of the disease, right? Manipulation is a symptom of the disease. And so I am lucky enough that because of my own history, I'm really in tune to whether or not people are using. I'm very good at spotting recent use in my clients, and so they avoid me like the plague when they've had a relapse. Because of that, and because of my ability to look at them in the waiting room and be like, uh-oh, there was a relapse, right? It is my job to, when they get into my office, for me to say, all right, when did you relapse? How bad has it gotten? And not be afraid to say it, right? And some of my clients are very committed to that narrative that they did not relapse. And I've had the conversation with some of them that they're like, well, Skye, but I really didn't relapse. And I'm like, well, I know that you did, so we're just gonna have to agree to disagree on this. And as a new therapist, I wouldn't have done that because it is very uncomfortable. But after being in the field for a long time, I know what I know, right? I'm gonna trust my instincts. And yeah, I know what I know, so.
Just talking about it will help their accountability.
Absolutely, right? Because people in active addiction, they're trying to protect that use. They're trying to protect the use from anybody else knowing about it or trying to get them to stop. So that's the type of accountability that I'm talking about. Not throw them in prison for the rest of their lives. Not that type of accountability. Yeah. Yes. Any other questions, or should we wrap up? I think Mary says wrap up.